All right, let's dive right into this. Today, we're breaking down our high-yield playbook for pediatric poisoning emergencies in this explainer. Look, if you're working in pediatric care, you already know that poisoning isn't just a random possibility. It's a profoundly unique, fast-moving medical emergency that demands rapid, incredibly specific interventions. To understand why this is absolutely critical, we really have to look at the patients themselves. Kids under the age of 6, especially toddlers, are at the absolute highest risk. And why is that? Well, it's just their natural developmental stage. They explore the entire world by putting literally everything into their mouths. That curiosity is totally normal, but it means medications, household chemicals, vitamins, it's all fair game to them. And here's the harsh reality of the situation. There is no single universal protocol or magic bullet antidote that fixes all toxic exposures. Instead, we have to identify the exact toxidrome, which is the substance-specific toxic syndrome, if we're going to save that child's life. To make these complex toxidromes super memorable, we've organized our explainer today into 5 quick sections. 1. The golden rules of toxicology. 2. The deceptive duo. 3. The airway threats. 4. Systemic disruptors. And 5. An antidote matchup. Starting us off, Section 1. The golden rules of toxicology. When a poisoned child rolls through those doors, your initial assessment dictates literally every subsequent decision. You have to immediately nail down the substance, the exact amount ingested, the route, and the time of exposure. Vague information just delays life-saving treatment. Simultaneously, get the Regional Poison Control Center on the line. They are your ultimate guiding partners here. But listen, here is the most critical rule of all. You must prioritize your ABCs, airway, breathing, and circulation over decontamination. Securing the airway and providing cardiorespiratory support always comes before you even think about trying to remove the poison from the stomach. And speaking of removing poison from the stomach, let me be emphatically clear about something. We do not induce vomiting. Suroc of ipecac is strictly contraindicated for routine poison control treatment. It's a dangerous practice from a bygone era. Why? Because if a kid vomits up certain chemicals, like hydrocarbons or corrosives, they risk aspirating that junk right into their lungs or severely reburning their esophagus on the way back up. Just don't do it. Moving right along to Section 2, the deceptive duo, acetaminophen and iron. These two poisons act like a biological Trojan horse in the body. Check out this timeline for acetaminophen or Tylenol toxicity. From 0 to 24 hours, the kid has general, vague symptoms, nausea, sweating, pallor. But look closely at the 24 to 72-hour window. There's an apparent improvement. Families and honestly even novice nurses are constantly falsely reassured by this phase because the child genuinely looks like they're getting better. Do not be fooled. This is just the quiet lull before a devastating hepatic storm. Between 72 and 96 hours, the liver starts to fail. Stupor, jaundice, and severe coagulation disturbances set in. This right here is the period with the highest risk of death. Now look at how perfectly supplemental iron poisoning mirrors that exact pattern. Within the first 6 hours, you get brutal GI symptoms, vomiting, hematemesis, bloody stools. But then from 6 to 24 hours, boom, a latency period. The child again appears to improve. If you let your guard down here, you are going to miss the massive systemic toxicity period that follows right behind it, featuring metabolic acidosis, shock, and eventual hepatic injury and coma. You have got to monitor these patients continuously through the entire stage timeline. So the crucial point to lock away is that early symptom resolution in either of these ingestions means absolutely nothing. They both share this highly dangerous fake-out phase. For acetaminophen, the greatest threat is hepatic failure, and we treat it with oral N-acetylcysteine. For iron, the biggest threat is massive systemic toxicity and shock, and its antidote is deferoxamine mesylate. Keep these two tightly linked in your brain because of their shared deceptive behavior. All right, Section 3, the airway threats, hydrocarbons and corrosives. These toxins abandon the whole Trojan horse trick and just cause immediate, brutal physical damage. If a child swallows a hydrocarbon, we're talking paint thinner, lighter fluid, things like that, they're going to be gagging, coughing, cyanotic. Here is your absolute highest priority rule, and I want to scream this from the rooftops. Intubate before decontamination. Protecting that child's airway with a cuffed endotracheal tube is absolutely mandatory before you even attempt to touch the stomach. The aspiration risk is just way too high. The exact same intense logic applies to corrosive products, like drain cleaners or strong acids.
Because these burn the tissues instantly on contact, swelling in the airway is a massive immediate risk. Airway readiness is paramount. You must keep the patient strictly NPO. And crucially, you have to teach families to never, ever attempt to neutralize an acid at home by having the child drink something else. Trying to cause a chemical neutralizing reaction inside an already damaged esophagus, that's just going to make the thermal and chemical burns so much worse. Maintain the airway and give analgesics for the severe pain. And that's it.
Which brings us to Section 4, Systemic Disruptors, Salicylates and Lead. Systemic disruptors completely bypass the gut and directly wreak systemic and neurological havoc. Salicylate toxicity, which most commonly comes from aspirin, presents in two distinct ways. Acute toxicity hits fast with nausea, disorientation, and a very classic clue, tinnitus, or ringing in the ears. You'll also see tachypnea, which is just the child's respiratory system frantically trying to compensate for the massive acid-based disturbance happening in their blood. Chronic toxicity is subtler at first, but features really dangerous bleeding tendencies and severe seizures. We diagnose this with a serum salicylate level and an ABG. The core treatments: activated charcoal, sodium bicarbonate to fix that acid-base imbalance, and in really severe cases, hemodialysis. Lead poisoning, on the other hand, is a whole different beast. Unlike other poisons where low-level exposure might not really show many symptoms, lead uniquely causes defining cognitive and behavioral delays even at very, very low doses. We're talking distractibility, impulsiveness, mild intellectual difficulty. At high doses, this aggressively progresses to severe cognitive delays, blindness, seizures, and even death. And regardless of the dose, lead universally damages the kidneys, causes hypertension, and triggers anemia. It is a devastating systemic disruptor. Actually, hold up. I want to pause right here and break the fourth wall for a second. If you've been reading your source material closely, you might have tripped over a really confusing contradiction. There is a major trap hidden in the text regarding the antidotes for lead versus iron. In one of the practice question rationales, it confusingly states that chelation Durab-E using deferoxamine mesylate is indicated for lead poisoning. Do not fall for this. It is a flat-out error in the source text. Let's clear that up right now in Section 5. Antidote matchup. Let's completely myth-bust that error and lock in the real pairings. For acetaminophen, the correct antidote is N-acetylcysteine, and your priority is to monitor liver function through that entire dangerous 96-hour window. For iron, the correct antidote is deferoxamine mesylate, again, not for lead but for iron, and you must monitor them through that deceptive latency period. Finally, for lead, the correct antidotes are DMSA, also known as Secumur, or CA-EDTA. Please burn these pairings into your memory so you don't get tripped up. As we wrap up this explainer, I want to bring our narrative full circle with this core thought. Early symptom resolution does not mean the danger has passed. This is hands down the most dangerous clinical trap shared by our deceptive duo, acetaminophen and iron. It's the exact reason we have to maintain strict, continuous observation of these pediatric patients long after they stop throwing up and tell you they feel better. So I'll leave you with this final thought to ponder. As you review this Toxidrome playbook, ask yourself, would you confidently recognize the quiet eye of the storm in a pediatric poisoning emergency before the real systemic damage begins? Pediatric emergency care requires high vigilance, deep knowledge, and the ability to look right past the immediate presentation to anticipate exactly what that toxin is doing behind the scenes. Keep studying, keep asking the hard questions, and you are absolutely going to master this. Thanks for joining me on this explainer.